I'd like to invite all of the speakers to come up, and we'll have a few minutes for Q&A. I give enormous credit to our speakers in trying to cram a huge amount of material into very short presentations. Our speakers who spoke online are also still available. If you have questions, please go to one of the microphones in the aisle, introduce yourself, tell to whom the question is directed, and please keep your questions, and I'll ask the speakers to also keep the answers brief. Yes, please.
Thank you. My name is Bob Yolkin. I'm an infectious disease person and pediatrician at Johns Hopkins. And first of all, I want to thank all the speakers. I think this was wonderful presentations, and certainly share learning a lot with everyone here. My question has to do with the analogy between CMV, which we heard about from Dr. Britt, and what you're seeing. So with CMV, as he mentioned, you'll see a lot of other factors such as small for gestational age babies, also probably some fetal loss. And has that been seen, I guess the question of Dr. Rosenberg, was that seen in the Polynesian island outbreak, or is that also seen in the Brazil outbreak?
To whom is the...
I asked Dr. Rosenberg about it in the Polynesian outbreak. Did they see also small for gestational age babies? I was going to ask the question, Dr. Ko, in the Brazil, what they know in the Brazil outbreak.
There were no detection of birth defects from YAP. It was a relatively small population, though, to keep in mind, probably 5,000 people, and we don't know how many of those were pregnant.
You said there's microcephaly in retrospect?
No, I say that there was none. As far as we know, I'm not sure how carefully it's been studied.
Let me just add, not in YAP, he said, but in the French Polynesia, yes.
Right.
Retrospectively, there were 17 women identified, of which about 11 opted for termination of pregnancy, and 3 of them opted to continue the pregnancy. And they were all identified by ultrasound with calcifications and microcephaly.
Let's go to this side for the question.
Yes. One of the things that we struggle with when dealing with the emerging news and science is how to counter actual risk from perceived risk. And pseudoscience with actual science. I gave you that introduction because there are 2 prevailing items that seem to be discussed, and I haven't really heard us as scientists, either from a public health or a medical side, address them and how to counter their impact. One being the most recent conversations about larvicide having some significant issue or potential or probable correlation to the microencephaly, and the other one being the other social media related science, pseudoscience around genetically modified mosquitoes being associated with this particular. So can we, from a scientific and applied science aspect, kind of quell or address those concerns so that we know how to educate our public better?
Yeah, I'll start with the second question about the transgenic mosquitoes. There have been very small contained releases in Brazil, but again, these male mosquitoes mate with wild females. They produce offspring that die 100% in the larval stage, so the transgene does not persist in the population. So between the very small scale of the releases and the lack of persistence, there's no way that could explain anything to do with the Zika outbreak. The first question about larvicide use, in a country like Brazil, and perhaps Albert can comment on this, I think there's very limited application of larvicides, especially in many of the poor communities where a lot of these cases are occurring in Salvador. There's absolutely no mosquito control available to probably the majority of people in these cities.
I'll just make it quick. I think the concern was with pyroprofaxin. I can't pronounce the name of that, but it's the the use of that in the Northeast, particularly where the epidemic has started, is very minimal. It's been used in other parts of the country, but not necessarily in the Northeast. It's also more used in rural for agricultural purposes than for urban. And much of these cases started in the urban centers.
Go to this side. May I remind you to give your name, please, before you ask a question?
Hi, Diana Weber. I am a AAAS Fellow at National Science Foundation in the Ecology and Evolution of Infectious Diseases. We have just put out a Dear Colleague letter on the Zika virus for rapid funding. And as a result of starting to look at the proposals that are coming in, what we'd like to know is what sort of data are or will be available. Last year with Ebola, one of the big issues with people who wanted to do modeling was access to data. So what is being collected and what is being made publicly available?
Whom would you like to...
Actually, I know this is a difficult question, so if anybody in the panel could put in any information, and if not...
I would volunteer our colleague from PAHO.
Well,
It's a good one. We're working on it. Remember, this was not a reportable disease. Countries are coming now reporting, and you saw a slide with EpiCurve. So data are flowing now, but still we have some challenges from some countries because they need to set the system, they need to improve this. So I don't see major problem with data being available. The issue is that countries owns their data and they like to discuss the issue. So as far as PAHO is always available to be brokered with the countries. But the data that I presented is in the website of PAHO publicly. So now, of course, there will be more data needs and so on, but I think it's a matter of and I understand the DG of WHO is going to Brazil because there has been some concerns and issue, but I understand also Brazil is working very well with CDC, and actually the case control study, part of the testing has been done in CDC also. So while there are constraints, I don't have a doubt that there will be data available and regarding Zika, Guillain-Barré, which is actually available, and microcephaly, which is only in Brazil.
thank you.
Let's go to this side.
A comment from the phone, if you can hear me. I don't know, Mary.
Yes. Please continue.
Okay, it's Tom Monat. Yeah, I just wanted to point out with regard to the congenital anomalies that this is not entirely unique among the flaviviruses, and point out I think it would be nice to have an animal model with which one could ask important questions about pathogenesis of the developmental embryo toxicity. And there are, Japanese encephalitis in pigs is commonly associated with congenital infection of piglets and an encephalitis leading to stillbirth often. And a mosquito-borne flavivirus in Africa called Wesselsbrand is often associated with similar findings in sheep with arthrogryposis and stillbirth and births with neurological anomalies. And I think this is an area for research that should go on in parallel with the Zika story, where currently we don't have any animal models that could be studied in this way.
Thank you, Tom.
Hi, Nikki Lurie. Thanks to all of the panelists for terrific presentations. I have two very different kinds of questions. The first, I think, is for our colleagues from PAHO, and that's it. It seems that there are a lot of people around the world now that are engaged in one way or another in epidemiologic studies or other more basic research studies, and yet I'm not sure that they all know that one another exists or how to find one another. Whether it's on the homology and vector side or whether it's on the epi side or whatever. And I am wondering whether any of you, but particularly you, might be aware of a central place where people who are doing work could at least declare that they are, so that we can start to develop a broader research network. The other question has to do with vector control, and I'm just wondering whether there are any precedents for using crowdsourced information to identify reservoir vectors, standing water, other sorts of things, so that others involved in eradication could, go there and do something. If I think of, you know, the analog in Deepwater where people reported oil birds and somebody went and washed them off. I don't know whether there's any experience with using that kind of information for vector control, but if there is, it'd be great to hear. Thanks.
I'll comment on the vector control. I do know some programs that are making use of smartphone technology for people to report presence, densities of vectors in different parts of the world, and to have this trigger some kind of an alert system for dengue in the past, perhaps now for Zika.
Citizens learn how to learn what to report and report it? Ordinary.
I don't know the details, but these are very simple, I've been bitten by a mosquito in my house kind of reporting. Nothing very sophisticated. Probably soon there will even be the opportunity to photograph a mosquito if there's one you can kill without mutilating it to the point of beyond identification. Things like that are being developed but not ready yet. The question about information on expertise, resources, I do want to point out that the Global Virus Network, and Dr. Esparza is here, who's the president, can comment more about this, is working very hard to compile a database of expertise from around the world, special resources, reagents, study populations, things like this to improve communication globally for Zika research.
Let me just add to that. While I mentioned some of the studies that are running in Brazil and Colombia, it is a valid question, but it's not an easy one to deal with, because we should understand that Brazil is a federal country with 5,000 municipalities, a strong academia network that are collaborating not only with scientists in the United States, but also Germany, Europe. So a lot of studies are going on. And while PAHO will try to be a broker on this one and to get information, we have some coming from the government, but it will be difficult to have all the information. But I think it's a valid question, and it should be, we should try to get as much as possible the information. But it is a huge now issue going on between the countries. Colombia is also doing a couple of studies, but I don't have a doubt that there's also several academia and research centers in Colombia, which is a very good National Institute of Health also, establishing bilateral collaborations with academias from the north and from the south.
Go to this side.
Good morning. Good morning. Umair Shah, I'm the Executive Director of Harris County Public Health Department in Houston, Harris County, third most populous county in the U.S., and operate the mosquito control program for the entirety of Houston and Harris County. Thank you for your presentations today. All of them were spot on. From a public health practice standpoint, we're obviously very, today as I was listening to the comments, I went from oscillating between optimism and oh my gosh, right? So in between. And really, my question is about the real vectors and the real Aedes and the QLEX concept. As we know, and as you all have shared, is the real possibility that QLEX mosquito might really be able to also be able to transmit Zika virus. While we have QLEX mosquito in our population in Houston, we also have Aedes in our population in Houston, and certainly have to continue with West Nile virus activities and a completely different strategy for Zika virus, et cetera. So the question I have for you is twofold. Is one, which disease pattern should we be either hopefully watching? Is it West Nile? Is it dengue? Is it CHIKV? To give us a little bit of a trajectory if you had a crystal ball. And then the second is there any real opportunity for delaying the onset of our mosquitoes contracting Zika virus?
So I think the response to the first question would be our recent experience with dengue and chikungunya is probably the best predictor we have at this point of what we may see in the U.S. with Zika. As you know, we've had local transmission of dengue involving up to thousands of people in Florida and South Texas, smaller numbers even in Houston. I think chikungunya surprised many of us in that we only saw I think 14 autochthonous cases in Florida in 2014 and none last year, even though we had thousands of imported cases diagnosed. So I think Zika, we're not expecting outbreaks of millions of people. We don't have the same level of exposure to Aedes aegypti that people do in the Caribbean and Latin America. But I think that the other question about what other vectors can be involved and what can we do to limit transmission, I think there's certainly the possibility for probably any of these viruses to very occasionally be transmitted by a different mosquito species. There are many mosquitoes out there that are susceptible to infection and can transmit in a laboratory experiment, but they just don't have the right level of contact with people. Culex quincunfasciatus is a great West Nile vector because it feeds a lot on birds. It occasionally feeds on people, but I don't think we're going to see efficient Zika virus transmission except by mosquitoes that focus a lot on humans as their hosts. And the other question about what can we do, I think ideally, if we were in a situation where we could very quickly diagnose imported cases and we had an efficient control program like Harris County's, which is really one of the best in the country, they would be prepared to go to that person's home, do some local treatment in their house and surrounding houses, and that could reduce the chance of the cycle beginning in a place like Houston. Unfortunately, we have all these asymptomatic cases that we're never going to identify, so that strategy is probably not going to have a very big impact. But if we do enough surveillance that we detect circulation very quickly in a place like Houston, then again, I think we can intervene by doing a perimeter-based approach to try to contain that if we can detect it very early.
I might just make a general epidemiological observation too, which of course you're very well aware of in Harris County, which is that West Nile virus is a bird virus. And if you're infected with West Nile virus, it's because you've been bitten by a mosquito that had bitten a bird. There is no transmission from human to human of West Nile virus by mosquito, which is a different case, of course, with chikungunya and dengue and Zika. Those provide two very different kind of epidemiological pictures. And in particular, in the case of controlling an outbreak, we probably will have somewhat better luck with Zika than we will with West Nile, where we have no control over the bird population.
Thank you. Lynn?
Yeah, I have a question about the ability...
Lynn Goldman.
Lynn Goldman, hi. Thank you, Mary. About the ability to actually identify the Zika virus in mosquitoes. And that is, we've heard a lot about the clinical tests and the sensitivity and specificity of those, and that there's a fair amount of ability to distinguish it from dengue, but not completely. And what about in assessing levels of virus carriage in mosquitoes? Can we distinguish it from dengue and chikungunya or not?
So there are PCR tests available that are very specific and very sensitive that could be used to screen mosquito pools. And in fact, again, back to Harris County, they're working towards implementing this in the next few weeks. They collect Aedes aegypti throughout the warm part of the season. And in the past few years, they've tested all their pools for chikungunya virus. I suspect pretty soon there will be a dipstick type assay, which is available now for chikungunya, works very well for mosquito pools. It has limited sensitivity, but the typical amount of virus in a mosquito that's capable of transmitting can be detected with that dipstick assay. So again, Harris County has been using that for a couple years, and then they can do confirmatory work through PCR if they detect a positive with that assay.
And that's been developed for Zika as well, or chikungunya?
Well, the PCR is available now for Zika, and I suspect that the same company that developed those, they're called VEC tests, those dipstick assays, is working very hard right now to develop a Zika test.
Go to this side.
Thank you. My name is Tonsai Raju. I am from NICHD, NIH, right here. Thank you for the fascinating set of presentations. I was reflecting on the neuropathology two kinds of neuropathologies. One is in the fetus you have microcephaly, whereas there is no white matter damage. There doesn't seem to be, at least in the clinical manifestation of these children. And whereas in the Guillain-Barré syndrome seems like a demyelinating condition. So there may be some molecular clues about why these differences in these viral pathogenetic mechanisms. One may be that early in that gestation, up to 12, 13 weeks of gestation or beyond, there's hardly any myelination is going on, but mostly there is a gray matter neuronal formation and migration of these neurons from the periventricular zones into the periphery of the brain. Whereas in an adult, if I assume rightly, the Guillain-Barré syndrome was predominantly demyelinating, seen in much older people. So if we can understand why these differences and how this may be, there may be molecular targets to find out the pathogenic mechanism and to even prevent it. So I just wanted your comments on that. Has Guillain-Barré syndrome been seen in children or younger children or only in older people?
So I'm not sure, but the French Polynesian experience, I believe they're all adults. And at least in the Brazilian cases, there's a bias towards elderly, just like Guillain-Barré in general. So in going back to the question about the mechanism, it's not clear if there's a link between the two. We still need to know, just the autopsies that just were published last week. The one which was probably the interesting one, which was the one from the MMWR, I think there were 2 spontaneous abortions around 18 or 20 weeks. They didn't really go into depth about the autopsy, or they identified virus in the brain by PCR. They didn't really go into the histopathological findings. I think what we would suspect is that and just maybe to make a caveat, and this was an earlier question, we don't really know what the distribution is. This is Bill Britt brought up that a lot of the findings that are in both the fetus and in the newborn are actually things that you see in a lot of congenital infections. We see this in toxoplasmosis. We see it sometimes in syphilis, certainly in CMV and sometimes in rubella, the Ageria, the ventriculomegaly. The one thing that's different about this is really that we can't find virus outside of the brain, but that may be because we're not looking at the right time, or we're not taking snapshots. We have, in Salvador, we are having quite a number of stillbirths, and we actually it's going to come out in the next week, but we have cases of hydrops, which calls into the question of this. So there's a lot more hydrops fetalis, so there's a lot more we need to find out about this.
Thank you. So Guillain-Barré may well be autoimmune disease seen in adults, which doesn't usually happen in the fetus. So, thank you.
Yeah, no, and we don't see anything like that in the fetuses. That's right.
I'm sorry, I regret that we have to cut off the questioning. There will be much more time for discussion during the breakout sessions this afternoon. I'd like to now again thank the speakers and invite my co-chair, Dr. Griffin, to make some additional comments.
Okay, well, it's my job. First of all, thank everybody for this morning session, which I think has been fantastic. And it's a prelude and background for the breakout sessions that are going to be this afternoon. And so the first, if you go to the next slide, I think this is the overview, but yeah. So first thing is lunch. And lunch, for those of you who are able to register for a breakout session, you have a yellow ticket in your name badge, which you can give to a staff person in the Great Hall who will give you and then you will also get a box lunch. We're hoping that there will be some left over because people might not all have been able to come. For those of you who are not able to register for a breakout, but you'll have to wait to see. So if you're not registered, you don't have a yellow ticket. But there's also a cafeteria in the basement where you can get a lunch. So for the breakout sessions, go to your assigned room, and there we will continue the discussion with additional talks, and then that information, identification of questions, et cetera, will be compiled, and then we'll come back here and go over the outcomes from each of the breakout sessions. So you'll get more instructions at your breakout. I think we have, here are the rooms for the breakout sessions. Okay, see you back here.